Welcome, my friends, to the Bob and Brad podcast produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. Today, my guest is an orthopedic surgeon, Dr. Brent Warner. And Dr. Brent Warner does a lot of arthroscopic surgery. He does the shoulder and the knee and even the hip sometimes. But today we're going to talk about knee menisci or meniscus and ACL surgeries and also shoulder rotator cuff repairs. So enjoy the program and you'll definitely will learn something. Welcome to the program, Dr. Warner.
Hi, thanks for having me. I really appreciate it.
So let's switch gears here a little bit and go to an ACL surgery in your recommendations. So, you know, this is the surgery I was afraid, injury I was always afraid my son was going to get. So, any inroads to prevention at this point?
Yeah, absolutely. You know, if you look really at any, especially kind of lay press stories on ACL injuries, everything will tell you that we're seeing increased incidence of these in young people. Now, some of that's probably just because young people are increasingly active, right? There's all kinds of different sports and activities they can get into. And so it's just maybe a case of exposure, right? More people doing more things where they might possibly get hurt. But, even apart from that, it does seem like there has been some increase in recognition and incidents of these types of injuries. So a lot of people are trying to figure out, well, what can we do to minimize that, to reverse that trend? So there's a lot of good research that has been done looking at ways to prevent these tears. A lot of it boils down to kind of the biomechanics, of the lower extremities, and really a lot of it kind of core strength and things too. So the way people say jump and land and how their knees absorb that pressure and shock, how the knees might twist, inward or outward, strengthening all the muscles around the knee and in the pelvis and the glutes and the core and all of that. Those have downstream effects on how the knee functions and the biomechanics of it. And some of these programs have been shown, they really do look like they can help prevent at least some part of ACL tears or some proportion of them. Sadly, I don't think anything is ever going to make that risk zero. But yes, these prevention programs, I think, can be great, especially for particularly high risk patients or high risk sports. One of the most high incidences we see is in female soccer players, for example.
Yep.
There have been a couple of good studies out there showing that if you put your women's soccer team through one of these prevention programs, you are probably going to see a decreased number of these types of injuries.
Sure. And you're going to get the question, can it heal on its own?
With very few exceptions, the answer to that one is no. If we think about kind of where the ACL sits in the knee, it kind of makes sense too. So there's four major ligaments that sort of hold the knee together. On the sides of the knee, you have the collateral ligaments, the MCL, and the lateral collateral ligament, LCL. Those are actually sort of exterior to the joint itself. They are not inside like the capsular lining of the joint. So they're surrounded by other tissues and a lot of blood vessels and things. So injuries to those ligaments maybe have a bit better ability to heal themselves. The cruciate ligaments, the ACL, anterior cruciate, and the PCL, posterior cruciate ligaments, they're actually right down in the center of the knee. They kind of crisscross one another. That's why they're called the cruciate ligaments. They're like a little X in there. They attach actually to the bone. One end attaches to the femur, the other end attaches to the tibia. And then it's basically suspended there, and it just kind of floats in the fluid inside of your knee. And there's really no way for, blood vessels to bring nutrients to that tissue to get it to heal. So if you've torn your ACL, the chance that it heals is very, very small.
So basically the two ends can't find themselves. I mean,
exactly. Right. Yeah. The two ends can't find themselves. There's some thinking that tears that where maybe the ligament just kind of pulls just directly off its bony attachment because it's then potentially close to the bone, and the bone has some blood supply. Those are the ones that are felt like maybe those can heal a bit better. But yeah, if you have a tear kind of right in the middle of the ACL, which is honestly the most common pattern we see, those ones really will not heal on their own.
So there's two surgeries, I guess, reconstruction versus repair. Can you explain the difference?
Sure. The real mainstay of treatment is reconstruction.
All right.
So repair would be where you take those two torn ends and like stitch them back together to try to get that tissue to heal primarily. And that's something that was tried a long time ago. And most all the studies showed that really failed in the vast majority of patients. There's a small subset of those patients where, again, those tears that maybe the ligament pulls just off of the bone.
Sure.
So the majority of the ligament is pretty normal. It's just that, one attachment point. Those ones did a bit better with the repair strategies in those older studies. And there has been something of a return of that. It's a little bit in vogue right now where more people are kind of, looking at more repair type strategies. Most of those are focused on those kind of specific tears, but those are really, really, in general, pretty infrequent. And I think a lot of the jury is still out on whether those repair strategies are really, truly working. Are they as good or are they better than reconstructions? I'm not sure anybody has kind of shown that conclusively yet. And there's also a lot of really neat research going on where other people are trying to do repairs and sort of add things to either, kind of wrap around the ACL to kind of keep blood supply or other nutrients there and sort of really augment that healing. So, eventually down the line, is it possible that repair might become more viable kind of everyday treatment for this? I think that's possible. But as of today, really, that's not the main treatment we see. So again, what we do much more commonly is we do a reconstruction. So what that means is that the damaged ACL tissue, the torn tissue, actually gets removed and it gets replaced or reconstructed with a graft of some type. We're taking new healthy tissue and then basically implanting that inside of the knee where it becomes now the ACL for that patient in that knee.
Is that, as a surgeon, is that your biggest decision? Like what kind of graft I'm going to do, or?
Yeah, it is certainly amongst the biggest decisions when we're doing this. There's a number of different factors that we think of when we're kind of making that choice. And typically that's a pretty big part of the discussion I have with the patient. Once we've kind of concluded that, okay, surgery is the right answer, then the next question that follows is, all right, what are we going to use for that graft and why?
So what are the choices?
Yeah. Broadly broken down, there's really kind of two categories. So you could either use tissue from that own patient, and so that's called autograft tissue, or you could use tissue from a cadaver. That's called allograft tissue.
Sure. And what parts of the body are the autograft?
Yeah. So almost always we're going to take that tissue from right around the same knee that we're already working on. Sometimes in, say revision settings where somebody might need to be having an ACL surgery done over again, we might end up taking tissue from somewhere else, often like the opposite knee or something like that. But mainstay of treatment is to have that tissue taken from right there at that same knee that we're already doing surgery on. And then there are a couple of choices there that have their various kind of pros and cons. The two that are, probably still most common that most people might have heard of would be to use a part of the patellar tendon. So that's the tendon that attaches the kneecap or patella to the tibia, the shin bone, right in the front of the knee. It's a nice broad flat tendon, and we can take a strip kind of right out of the middle of that tendon along with a little bit of bone from the tibia and the kneecap. And so that's kind of maybe the sort of oldest sort of gold standard tried and true graft. That was one of the first ones that people used for this surgery back when it was developed. Another would be to use hamstring tendons. So that's another one that's very, very common. So your hamstrings are the muscles that run down the back of your thigh. And two of those muscles have pretty long, slender tendons that actually attach to the shin bone, kind of right below the level of the knee joint. And so we're able to harvest, as the term we use, basically harvest those tendons and then kind of fold them up on themselves to become the right length of an ACL, and that becomes the graft. So those are probably the two most common worldwide and in the US. The third option, which has become a bit more popular here recently, and which I honestly am quite a fan of, is to use a part of the quadriceps tendon. So the quadriceps muscles are the thigh muscles on the front side of the leg, and the quadriceps tendon is a nice, big, thick, wide tendon where those muscles come down and then attach to the top of the kneecap or the patella. And so somewhat similarly to the patellar tendon graft, we basically take a strip of that tendon kind of right out of the mid portion of it. We're able to, repair that back afterwards. And that has become a really nice, reliable graft for us that I like quite a bit.
So you said a lot of people ask, is this a painful surgery?
It does tend to be a bit painful. To implant that graft inside of the knee, we're doing a combination of both arthroscopy and kind of open surgery. So arthroscopy means I've got a little tiny camera down inside of the knee where I can see everything up close and magnify it on a screen that kind of sits, just a few feet away. And then we also do have to make a couple of different incisions on the knee. One of those is going to be to harvest that graft tissue. Another one or two of those incisions are going to be to help us actually implant that graft into the knee. And to do that, we drill tunnels. We drill holes in the bone of both the femur and the tibia, right where that ligament would normally attach. And the graft essentially gets kind of pulled into those little tunnels and secured there in some way. There's a number of ways to do that. So with all that work, usually a couple of incisions, drilling holes in the bone, borrowing tissue to become our graft, that does all cause some pain. Now, we do as much as we can to combat that for the patient, right? They're going to be asleep during surgery under anesthesia,
Sure.
so they shouldn't feel anything during the procedure itself. Here at my group, and I think most places, we're very high on using what's called regional anesthesia as well. So that means that anesthesia, our providers there would actually give an injection of some anesthetic numbing medication to that patient into their leg, which is going to basically numb the knee and the majority of the leg along with it. So typically when patients wake up from surgery, they don't have all that much pain right away. That block typically is going to wear off within a day or so. And usually they will see their pain increase somewhat. But then we help them control that. They're going to have a couple different types of pain medication. They're going to be icing their knee. They're going to be in a brace to help protect it and control, how much motion it can go through and that kind of thing, all of which is going to help. And so, yes, the first couple of days, once that block is worn off, that can be a little tough for people, but also very manageable, right? And typically within a week or two of surgery, people are starting to feel more like themselves again.
Well, thank you again, Dr. Warner. Very impressive, great information, and hope some people will check you out because you're in that zone. You're a lot of surgeries, but you're young. So,
Yep. Yeah.
All right. Thanks.
No, thank you so much for having me. It's been fun. I really, really appreciate it.
Yep. Thanks for being on.